healthcare professionals. Today, in this video I am going to share with you second case in the series on diagnosis. The series of interesting, uncommon and challenging cases which I came across during my clinical practice while working in ICU over last 28 years. Videos are helpful for all healthcare professionals. Here, I will share a real case that was presented to my intensive care unit. Though this patient was not critically ill but diagnostically interesting in the sense that diagnosis which appeared initially was not the final diagnosis, and simple mistake of not making right diagnosis would have led to unwanted and unwarranted consequences in this patient. I will share the real story and I will walk through real scenarios so you can connect this story with real-life clinical situations. So, let's embark on this story of making the uncommon diagnosis and how it impacted the management and outcome. Let's begin with our case. A 45-year-old man presented to hospital emergency with a one-day history of left chest pain and mild short of breath. There was no other associated history, including history of trauma, fever, orthopnea, sweating, or any medication intake. On presentation to emergency department, he was conscious with stable vitals. He was seen by emergency physician and evaluated. There was no past history of diabetes, hypertension, heart disease, or stroke. He was non-smoker. He was a case of neurofibromatosis. On initial examination, there was decreased breath sound over left chest with dullness on percussion. Chest X-ray that was done in the emergency department revealed left side homogeneous opacity without air bronchogram and mediastinal shift to right consistent with the diagnosis of massive left pleural collection. Contrast CT scan chest was done as a part of evaluation did not reveal anything significant apart from massive left pleural collection as reported by radiologist. Case was discussed with chest physician and diagnostic thoracentesis done which revealed hemothorax. Chest physician wants to insert thoracic drainage tube in view of massive collection and mediastinal shift to right. What is your opinion based on the given information? Whether chest physician was moving in the right direction. ICU team kept therapeutic drainage on hold since we want to know the underlying cause of non-traumatic hemothorax prior to any therapeutic procedure. Why hemothorax in this patient? This was our dilemma. ICU team could not find any explanation of hemothorax in the radiology report. Case was discussed with radiologist, but we could not draw anything conclusive. ICU team looked into the possibility of any relation of spontaneous hemothorax with neurofibromatosis. We reviewed the literature and to our surprise, neurofibromatosis can be associated with spontaneous hemothorax due to vascular abnormalities like dysplasia or aneurysm causing rupture or bleeding into pleural cavity. We again discussed the case with radiologists to specifically look for any rupture of blood vessels into pleural cavity. On our request, radiologist evaluated the scan again thoroughly and find ruptured blood vessels into left pleural cavity explaining left massive hemothorax. So, what could have been possible if we proceeded with therapeutic pleural drainage in this patient? Drainage of pleural cavity is an important part of management plan, but without fixing the underlying problem, and in this case ruptured aneurysm, inserting thoracic drainage tube is like opening and draining a tap where incessant bleed can cause major morbidity and likely mortality if aneurysm is actively bleeding. If we proceeded with draining collection, this situation could have worsened the patient condition leading to uncontrolled bleeding. By establishing the underlying cause of left massive hemothorax, hence, by establishing the correct diagnosis, we were able to prevent likely morbidity and mortality. So, diagnosis of this patient was not left pleural collection or left massive hemothorax but aneurysmal rupture of posterior intercostal artery leading to hemothorax subsequent to neurofibromatosis. Left hemothorax was a finding. We referred this patient for interventional procedure to a higher center where patient underwent interventional radiological procedure. So, establishing an underlying diagnosis is an essential component of treating patients. Healthcare professionals should be cognizant of the difference between diagnosis, which is main underlying cause, findings which may be clinical, radiological, or laboratory, and presentation of patient which consist of main symptoms. Misdiagnosis can lead to incorrect treatment, complications, and potential morbidity and mortality. Hope this was an interesting case. If you like this information, Please subscribe to this channel for more interesting and challenging diagnosis.